Chapter 22, Respiratory Tract Infections of the Adult and Pediatric Patient. So, there are three common respiratory viruses that occur, or respiratory diseases that occur within adults. That would be the common cold, rhinosinusitis, or sinus infection, and influenza. The signs and symptoms will depend on which structure is involved and the severity of the infectious process. Other things that play a part in the signs and symptoms are the age of the patient and the health status of the patient. In terms of the viral infections that we have here, rhinosinusitis and influenza, know that the virus has specific signature patterns. So the rhinovirus is generally considered an upper respiratory infection, while influenza can be both upper and lower. So the common cold caused by a virus generally occurs early in fall and late in spring in persons between the ages of 5 and 40. The flu virus generally occurs in children younger than 3, and the RSV virus is a common occurrence in winter and spring for children younger than 3. And then there are coronaviruses and adenoviruses. You generally don't need to understand the name of the virus, but knowing that the common cold is a respiratory infection that is caused by a virus. It is the most frequent viral respiratory infection. Signs and symptoms of all of these look pretty similar. Prodromally, before the outbreak, you get a sore throat. Then it moves to a runny nose, nasal congestion, sneezing, coughing, malaise, fatigue, and headache. Generally, a cold is self-limiting, lasting about 7 days, unless you get a secondary infection. It is rapidly spread through contact, with children being the most common reservoir, and these kinds of viruses are most contagious in their first 3 days, and it takes about 5 days to incubate. Treatment is not by antibiotics. Antibiotics are ineffective on viruses. You will see people getting antibiotics if they get a secondary bacterial infection, which usually is if the virus lasts longer than 7 days. We should be looking into a secondary bacterial infection. Other than that, treatment is rest, keeping the fever down, antihistamines, and that's generally what you're going to do to fix this. Rhinosinusitis or sinusitis is an infection or an allergy that causes an obstruction in the sinuses. People with nasal polyps that have swimming or that are swimmers or been in airplanes are at risk. It can be acute, subacute, or chronic, but basically the signs and symptoms are facial pain, headache. There is generally a purulent nasal discharge, pain on moving the head, particularly when bending over. Additionally, there may be maxillary pain or teeth pain. When you have a chronic sinusitis, there's a postnasal drip and a impairment of taste and smell with a chronic cough and fullness or plugging of the ears. Again, this virus is intended to be self-limiting, with it being 5 to 7 days. If you have a secondary bacterial infection, the pain actually gets worse rather than improving. Treatment is with mucolytic agents and corticosteroids. and inhalers, steam inhalations, air humidifiers, neti pots to promote the drainage of the sinuses. If you get a secondary infection, you need antibiotics. Influenza. Now, we generally think of influenza as a GI disease, but basically in the United States, 36,000 persons die a year of influenza-related illnesses. This is the most common upper respiratory infection that people get, and it's viral in nature. Is by, and the signs and symptoms are very much like the common cold, except for the tiredness or the weakness is definitely more profound. This type of infection may take weeks to resolve. In terms of signs and symptoms, it begins with a runny nose, which kills the first line of defense and allows the virus to spread further. Fever, chills, and malaise. There's a rapid onset, and it is a distinguishing sign and symptom because it, like the common cold, this is a viral pneumonia can take place from the flu virus. Signs and symptoms would include a fast respiratory rate, tachypnea, tachycardia, and hypotension. Generally, viral pneumonias have a rapid progression as soon as day one after the infection, and oftentimes we call these pneumonias walking pneumonias because people don't end up in the hospital, they end up fighting through them. All of these respiratory viral infections can lead to secondary bacterial infections, and those generally depend on where the bacterial infection ends up. So think about bronchitis, otitis media, and lung pneumonia. Generally, what happens with bacterial infections is you begin to feel better, and then you have a relapse, a productive cough, and the fever comes back again. In order to treat signs and symptoms, we're treating the, in order to treat a viral flu, we are treating the symptoms again. So we're giving antipyretics, analgesics, fluid, sleep, rest. Those are the most important treatment preventions. And then as we age, there are vaccines to help prevent, or for high-risk populations such as hospital workers, teachers, there is a vaccine to help lessen the signs and symptoms. The vaccine is only as good as their guess as to what the virus will be. Some years they guess very well, and we have less flu outbreaks. Other years, not so well, and we don't prevent the flu outbreaks. Remember, transmission is by aerosol, so that makes it very, very contagious. Bottom line, pneumonia, which is can be acquired in a bunch of different ways. We usually talk about pneumonia in terms of community acquired, which means the infection has begun outside of the hospital. And we talk about pneumonia as being nosocomial or hospital acquired, meaning it wasn't present on admission and presents at least 48 hours after admission. Pneumonias are in particular high risk in immunosuppressed patient populations, so think cancer patients, chronic lung disease patients, those with COPD and asthma, and the elderly. The signs and symptoms are related to the course of the disease. Fever is present and it's high, sudden malaise, a productive cough, that is that transitions from a serous production to a purulent production. How we diagnose pneumonia? Well, we do a chest x-ray and we see infiltrates on that chest x-ray. If there is a productive sputum, we will do a culture. We'll take a specimen and do a culture and sensitivity to determine what is the bacteria that's causing the problem. You will generally see an increase in the leukocytes, white blood cells. Oftentimes we'll do blood cultures if there's a high fever, just to see if the infection has spread to the blood. Depending on the patient's presentation or the age of the patient or the underlying disease, we may do blood gas levels to understand how altered the respiratory system is. And minimally, we will chart the SpO2, and we generally see reduced levels of SpO2 with pneumonia. We can vaccinate against pneumococcal pneumonia, and so you'll see us offering that to all of our elderly patients or immunocompromised patients as they're leaving the hospital, because we want to prevent them from coming back with that. In terms of treatment, we're going to utilize an antibiotic that is specific to the bacteria that we find on the culture and sensitivity of the sputum specimen. Again, we treat or we assist and support by humidifying air. Sometimes you'll see bronchodilators used. Sometimes patients, if they're already compromised, will end up on a ventilator, and we'll have to assist them to breathe for a while. But we want to make sure that they receive plenty of rest, a lot of medication to alleviate the pain, and we want to make sure that they maintain a high-calorie diet with plenty of fluids so that we can regenerate the healing process. Sometimes in atypical pneumonias, we don't really see the lung consolidation in the same way that we see on regular pneumonia chest x-rays. It looks more patchy. And in the atypical presentations of pneumonia, we may have a non-productive dry cough, which is part of what makes it different. Just a nice visual of how the onset of pneumonia occurs. Tuberculosis. So this is one of the oldest diseases that you'll see, and we see this in foreign-born or developing countries mostly, or as opportunistic, as an opportunistic disease of the HIV infected. Other incidents, high incidents, would be people that are in high-risk congregate settings, people that are living in small spaces. So think of overcrowded housing that occurs in poverty, or the homeless. Think of this as a prison disease, anywhere where they have lots of people living in small spaces with too many people and not enough air. There are drug-resistant forms of tuberculosis, but know that this is an aerobic bacteria that can stay alive and in your body, suspended in animation for years. The initial infection creates a cell-mediated immune response, and it takes about 3 to 6 weeks for you to develop a positive TB test. It is airborne and spread by droplets, and it's highly resistant to destruction. So it can live dormantly on pieces of material and be picked up that way too. Another high-level concept map. We can get secondary TB, so it's reinfection or reactivation of a previously healed primary lesion. Not a good thing, but know that you can get TB, and we call it secondary TB. The diagnostics are pretty much the same as what we do for primary TB. We get an acid-fast test of the sample. A TB skin test is generally what denotes that there's been exposure and a need for further investigation. Chest x-ray. Primary drugs that we use are INH, ethambutol, pyrazinamine, and rifampin, and we generally use these for up to a year if you've seroconverted or if we know that you have TB. These medicines are highly liver toxic, so while they cure the TB, they may cause other additional problems. Respiratory distress syndrome, generally something that we see in infants due to a lack of surfactant. Think of this as the primary disease of premature babies, birth before 38 weeks. Signs and symptoms occur within 24 hours of birth. You get a central cyanosis, a lot of lung retractions between the ribs, grunting on expiration, increased respiratory rate, and overall fatigue. We treat respiratory distress syndrome in babies with supportive care. Make sure that the baby is warm to prevent overstimulation of the homeostasis mechanism within the body because it's already working so hard just to breathe. We give oxygen, and we continuously monitor the cardiac system. If the respiratory distress is significant, we may put them on a mechanical ventilator with positive pressure to breathe for them. Couple of diseases to think about for children that you need to understand. Basically, respiratory obstruction in children can occur either in the upper airways or the lower airways. The signs and symptoms are a little bit different. If it's an upper airway disease, you have prolonged inspiration or an inspirational stridor, which is a noise of as they're breathing in. You have inspiratory retractions as the ribs are moved outward, and the body wall does not expand with the rib cage. When you have obstruction or disease processes that are in the lower airways, you have prolonged expiration with wheezing, heard in the lung sounds on the expiration. Three obstructive disorders that you'll see frequently within children. Viral croup. The prominent sign and symptom here is inspiratory stridor and a barking cough. It's usually preceded by an upper respiratory infection that seems like a common cold. We treat this by humidifying the air, making sure that the child gets enough sleep, and elevating the head of the bed when sleeping. Epiglottitis is an infection that is potentially fatal, causing edema of the epiglottis with a sudden onset respiratory distress and labored breathing because the epiglottis has swollen to close off the airway. Generally, we treat this by intubating the patient or putting in a trach to establish an airway. Lower airway diseases like bronchiolitis basically start with an upper respiratory infection that gradually turns into the development of respiratory distress with lots of wheezing, trouble exhaling, and difficulty eating and crying. Just a generalized distress with a wheeze rather than a bark or a inspiratory stridor.